Welcome to the PA CUSP Physics and Knobology lecture. In this lecture, we're going to define point-of-care ultrasound. We're going to cover some very basic physics. We're going to go over the basics of image acquisition and interpretation. Point-of-care ultrasound is a focused ultrasound examination performed at the bedside in real time. The main objectives are to answer specific clinical questions based off of a history and physical exam that you've obtained. It helps to assess the efficacy of prior interventions or to guide therapeutic interventions from the start. Point-of-care ultrasound in general, and this course specifically, is not going to turn you into a replacement radiologist, nor is it going to turn you into a replacement cardiologist. Your examinations should be confirmed with formal studies at a later date. Formal studies are going to A, confirm your findings, and B, provide a much more comprehensive assessment of whatever organ or area is being interrogated. So how do we actually generate an image? For those of you that don't have any significant experience with point-of-care ultrasound, it's really nothing more than a stethoscope for the eyes. Loosely translated, sonograph means writing sound. Ultrasound just refers to sound waves above the audible limit of human hearing. So when you put all that together, again, this is nothing more than a stethoscope for the eyes. If you've learned how to master a stethoscope in medical school and residency, learning how to use your eyes for that same sort of application is not a huge leap of faith. So how do you go about converting sound into images? Traditionally, the key has been related to something called the piezoelectric elements, or piezoelectric crystal. This is a crystal with specific properties that can convert electrical energy into acoustic energy and vice versa. As electrical voltage is applied across the piezoelectric crystal, the crystal produces sound waves through a series of expansions and contractions. This ultrasound wave or ultrasound beam penetrates tissues, some of which are reflected back in a term referred to as echoes. These echoes are converted back to electrical signals through another series of expansions and contractions, and these electrical signals are then displayed on the computer screen as a grayscale image. As the ultrasound beam leaves the transducer, there's progressive loss of energy referred to as attenuation. The degree of attenuation depends on a couple of different factors, one of which is the medium through which it's traveling. As an example, air is a near complete attenuating medium, and this is the reason why we end up using things like ultrasound gel and significant pressure to minimize the amount of air in between the transducer and the skin. High-frequency waves have very poor penetration, whereas low-frequency waves have much better penetration or much better depth. The consistency of the tissue also makes a difference in terms of the amount of attenuation. Homogeneous tissue has a much lower degree of attenuation compared to heterogeneous surfaces. So for instance, the interface between a pleural surface and the viscera would be a high area of attenuation, whereas travel through a relatively homogeneous structure such as the liver has a very low degree of attenuation. These tissue interfaces often act as mirrors. So small, smooth tissue planes such as pleural surfaces will reflect energy back towards the transducer. Depending on the angle of incidence or the angle that the ultrasound beam reaches the surface, a certain percentage of the energy will also be bent or refracted off. Subsequent imaging of progressively deeper structures will have more attenuation and will be more difficult to visualize. The default imaging mode is referred to as B mode or brightness mode. This is a two-dimensional image that converts the amplitude of waves into a grayscale. Strong echoes with large amplitudes are displayed as bright white, whereas the absence of an echo is displayed black on the screen. Intermediate echoes are displayed with shades of gray. Bright white lines are referred to as hyperechoic. Examples of hyperechoic tissue would include skin, tendons, and pleural surfaces. Anechoic areas are defined as black, and these are typically fluid, so blood vessels, gallbladder would be good examples of anechoic surfaces. Hypoechoic surfaces typically are fat, muscle, tissue parenchyma. These are varying shades of gray. So what do the various knobs and probes do, and how do you pick the right tool for the right job? There's really only a couple of buttons that you need to know to get started. Obviously, the power button to turn it on. Most machines will make you input patient information and operator information if you want to save any images. After that, you need to know how to select the correct probe, and then you're ready to start an exam. There are multiple different types of probes that come in varying shapes and sizes with varying scanner designs, frequencies, some of which with specific applications, some of which can be used on multiple different applications. The four most common transducers are phased array probes, linear probes, curvilinear arrays, and intracavitary probes. The phased array transducer has a very wide frequency range, somewhere in the realm of 1 to 5 megahertz. It has a very fast refresh rate, has a wide far field view. Basically, that just means the deeper you go, the wider an area that you can image. Has a very small footprint, so it fits well in between intercostal rib spaces. That can do varying modes such as 2D and Doppler and color. The most common use for this is going to be cardiac and thoracic imaging, although it can be applied for abdominal and transcranial imaging as well. The limitations of this type of probe are the lower resolution. The linear array is the exact opposite, commonly referred to as the vascular probe. This has a very high frequency, typically in the range of 7 to 15 megahertz, has a very high resolution. It's great near-field imaging, so superficial structures are shown in exquisite detail, but it has a very wide footprint, and it's not able to image deeper structures. Common applications would include vascular imaging, either for DVT studies or for procedural guidance such as central venous cannulation, nerve blocks, thyroid examinations and biopsies, etc. The curvilinear array is somewhat similar to the cardiac probe. It's a relatively low frequency probe, somewhere in the realm of 2 to 5 megahertz. It has a very wide far field and a very wide near field. It also has a very large footprint, so it doesn't fit in between intercostal spaces nearly as well. This is the default probe for abdominal examination, a lot of obstetric examinations, and the FAST exam. There's limited thoracic application here because of its large footprint and slow frame rate. So what does this look like in real life? The next three images are of the same patient at the same time and the same angle. The first slide all the way to the left shows an abdominal probe in imaging through the liver. The liver is a fantastic echo window. You have great resolution here. You can see the heart moving. You can rule out a pericardial effusion, but you have a lot of trouble getting good imaging of the heart due to the fast motion and the slow refresh rate on an abdominal probe. You specifically have a lot of trouble imaging the valves moving. In contrast, you lose some resolution when you use the cardiac probe here in the middle, but you have great resolution of the valves and other fast-moving structures here. This is why this is the go-to probe for cardiac imaging. Now, if you were to try to use the vascular probe to image the heart, you don't get anywhere near the depth required. You start to lose your image somewhere around 5 centimeters. You have fantastic image resolution, and this would be a good probe if you are looking for more superficial structures such as the diaphragm motion or the pleural motion, trying to rule out or rule in a pneumothorax. So probe orientation, what is it and does it make a difference? Probe orientation is going to become important as you try and figure out what structure you're looking at and where it should be. It's going to become especially important if you're using ultrasound to guide procedures in real time, because you need to know what left is, right is, and what's going to be deep or superficial as you try and move a needle through the tissue. As a general rule, you want to get in the habit of holding the transducer like a pencil, anchoring your palm onto the patient. This is going to give you a lot more stability and it's going to improve your image acquisition significantly. Every ultrasound probe has a transducer orientation marker. In this particular example here, you can see the transducer marker is going to be more of a bar than an actual dot, but it's going to vary by manufacturer and the type of ultrasound probe that you're using. The ultrasound transducer marker is going to correlate with a marker that's going to appear on this screen, typically a green dot or a blue dot, depending on the type of ultrasound machine that you're using. And the relationship between this transducer marker and the marker on the screen is going to help you define left, right, top, and bottom. As a general rule, you're going to make the transducer orientation marker match the location of the dot on the screen. So the dot matches the dot, as the phrase goes. So here's a view of an ultrasound image. You'll notice up here this green dot is going to be the orientation marker. The upper portion of the image is going to correspond with superficial structures in this particular case, so things like skin and subcutaneous tissue is going to be up here. Right and left orientation is going to vary by convention. So if you are using a cardiac probe and your machine is programmed to do cardiac imaging, this orientation marker is actually going to appear on the right of the screen. You're going to take the index marker on the probe and direct that either towards the patient's head or towards the patient's left. While this does sound a little bit backwards, the left side of the patient is the way you hold your ultrasound machine is typically going to correlate to the left side of the patient and the right side of the screen. So the dot is still going to match up with the index marker itself. Unfortunately, the radiology and the emergency medicine convention places the ultrasound orientation marker here on the left-hand side. So for your probe positioning, you're going to put the index marker either towards the patient's head or towards the patient's right, which will then correlate to this left side of the screen here. The image that you obtain is going to depend on the plane of cut and the relationship between the index marker and the orientation marker on the screen. Typically, you're going to keep the ultrasound machine on the same side of the patient's body as yourself. So if you're imaging in the coronal plane and you're keeping the ultrasound screen towards the patient's head, the left side of the screen is going to correlate with the superior aspect of the patient. The bottom part of the screen is going to be more medial structures, and the right side of the screen is going to be more inferior structures. Similar for the sagittal plane, you're going to keep the index and the orientation marker in the same position. Superior is going to be on the left, inferior on the right, and posterior structures are going to be represented by the bottom of the screen. If you're using the transverse view, the posterior structures are going to be deeper and superficial structures are going to be more anterior. I find that especially for transverse imaging, it's easy to flip the left and right, and so an easy trick is just to tap the ultrasound with the gel on it and see which side of the screen your finger is actually affecting, just to make sure that your left and right orientation is correct here. As you move the ultrasound machine around the patient's body or you change your orientation, such as if you're standing at the head and doing an IJ, it's easy to flip that orientation. So a simple check before you start imaging will help keep yourself in the correct orientation here. Manipulation of the ultrasound probe has a couple specific terms that we should be familiar with as well. The first term is referred to as sliding. To slide, you're going to keep the ultrasound probe in a fixed position and then move the entire probe along the patient's body. Common examples of this would be jumping in between rib spaces to optimize cardiac imaging. Rotation is the second term. Similar to sliding, you're going to hold the ultrasound in a fixed position, but you're going to twist it along its central axis, much like a corkscrew. The next term that we need to be familiar with is tilting, sometimes referred to as fanning or sweeping. The transducer is going to be held in a fixed position, and then the angle is going to change along the long axis. In effect, this is going to give you a series of cross-sectional images through a single organ. A common example of this would be cross-sectional imaging on the short axis of the heart. The last term that we need to be familiar with is something called rocking. Similar to tilting, but this time you're going to change the angle along the short axis. As you move the transducer probe along its short axis, you're going to help to center or move the ultrasound image around the screen. So every ultrasound machine comes with a ton of different buttons. There's really only a couple, though, that you need to be familiar with to get started. The two most important are going to be gain and depth. Gain refers to the intensity of energy. The more gain or the more energy you supply, the brighter the image is going to appear. As you decrease the gain, you're going to provide less energy and you're going to have darker appearing structures. Depth is also important. You want to make sure that you're starting at an adequate depth. Always start deeper than you think you need to ensure that you're not missing anything important, and then decrease your depth to center in on the object that you're trying to image. Typically, you want to set the area of interest somewhere around the middle to the upper third of the screen. Here's just an example of various gain settings. The image all the way to the left is going to be a very low gain setting where you can see how it's difficult just to image where the actual vessels are. The middle image is going to be a very high gain. As you increase the gain, you're going to actually gain you're going to have a little bit of extra artifact, and it's easy, especially for things like vascular imaging, to convince yourself that there's a DVT when there's not actually anything within the vessel itself. The image all the way to the right would be what we would consider optimal gain. You have good gray-white differentiation, you can see the structures but without any kind of excess brightness. Here's an example of depth of field. So the image on the left is a parasternal long axis view of the heart with the right ventricle and the left ventricle labeled appropriately. Unfortunately, with this view, you are missing the massive pericardial effusion that you can see on the image on the right. Again, this is the same patient, same time, just a little bit of cropping and changing of depth. But you can see where it's important to make sure that you're really starting deep to make sure you don't miss anything important, such as a large pericardial or pleural effusion. So as great as ultrasound is, there are a certain number of artifacts, some of which are going to cause us problems, some of which we can use to our advantage. The first artifact that we're going to talk about is one that is actually critical to lung ultrasound and something that we can use to our advantage. It's referred to as a reverberation artifact. As the ultrasound transducer emits sound waves, they're going to bounce back and forth between the probe and a reflector. As this ultrasound beam bounces back and forth, eventually it will make its way back to the probe. For reverberation artifact, because it's bouncing back and forth or reflecting back and forth between two objects with a fixed distance, as it returns back to the ultrasound probe, either here through the first set and back, the second reverberation and back, or the third reverberation and back, the ultrasound probe doesn't realize that this is the same beam that it initially sent off a while ago, and it's going to assume that these are new echo reflections coming back from deeper and deeper structures as the time course is longer in between the transmission time and the reflection time. To confirm that this is a reverberation artifact, you're going to notice that there are a series of lines that are the same distance between the skin and the pleural surface and each reverberation line thereafter. This is one of the key components that we're going to use for lung ultrasound, and we'll go into this in more depth during the lung lecture. Mirror imaging artifact is somewhat similar to reverberation artifact. The primary beam is going to reflect off of a bright pleural surface, in this case the diaphragm, but instead of going directly back to the transducer, it's going to encounter another structure, in this particular case a nodular liver lesion, and it's going to reflect back and forth before ultimately making its way back to the transducer probe. The net effect is that it's going to duplicate the image, but at a deeper and slightly more lateral aspect, and it's going to make it appear as if the liver lesion is either duplicate or outside of the liver itself. One of the ways you can correct for this, or to confirm that this is indeed an artifact, is to change the angle of interrogation. As you change the angle of interrogation, the angle that the ultrasound probe is approaching will vary, and you won't get this same sort of mirror imaging and reverberation occurring. Shadowing is an effect that you'll see when trying to ultrasound high attenuating objects such as gallstones or ribs. Distal to these very high attenuating structures, you are not going to be able to image anything. As these high attenuating structures either absorb, scatter, or reflect all of the ultrasound energy, nothing is able to be transmitted distally. As we know from the early part of the lecture, if there's no ultrasound energy that's being reflected back, it's going to be represented as black. This can be helpful in certain instances, so it's fairly diagnostic for gallstones. It can also be a colossal pain if you're trying to image the heart, and the ribs are blocking any of your ultrasound waves from traveling more distal. Posterior acoustic enhancement is the exact opposite of shadowing. It's commonly seen distal to fluid-filled structures, again, such as the gallbladder or through the bladder itself. Sound is relatively unimpeded as it travels through fluid, so anything imaged distal to a fluid-filled structure is going to become very intense, high amplitude, and represented as very bright compared to surrounding tissue structures. So what other modes of imaging are available? Probably the second most common imaging mode is going to be referred to as M mode or motion mode. This imaging modality records motion at a single location and is plotted as motion versus time. This is a good way to calculate depth or excursion, to measure the dimensions of cavities, and also to assess for the motion of structures such as lung sliding and evaluation for pneumothorax. Doppler imaging assesses the frequency of moving objects. The frequency is going to increase as an object is moving towards the monitor and decrease as it's moving away from the monitor. Everyone's experienced this at some point in their life, standing on a train track. As the train's coming in, it's got a very high frequency pitch, and as it's leaving, it has a much lower frequency pitch. Typically, this is going to be applied to red cell velocity. The acronym to be familiar with here is BART, which stands for blue away, red towards. On the three images to the right of the screen, we have IJ and the carotid artery, respectively. The top image is just your typical B or brightness mode. Here's the vein, here's the artery. On the next image, down here in the middle, we're holding the vascular probe oriented slightly towards the patient's head. In this particular case, blue away corresponds to the artery because the artery is pumping blood from the heart towards the head. With the probe angled slightly towards the head, a venous return is coming towards the probe and is represented as red. Now, if we were to angle the probe towards the patient's heart, the image would flip. So blue away would correspond to venous flow flowing away from the probe towards the heart, and arterial flow leaving the heart traveling towards the head and towards the probe in this particular case, represented as red. It's important to remember that you can actually miss some significant amount of flow because each of these Doppler scales have a specific velocity that they're supposed to be correlated to. So the velocity of peripheral vasculature is going to be significantly different than the velocity through the heart. Making sure that you have the proper scale is going to be a critical part of adequately applying colored flow Doppler. With all that being said, go forth and ultrasound. Pay particular attention to the effects of various probes if you try and image the same part of the body, as well as the effect of moving the index marker or the orientation marker on the probe and ultrasound machine, respectively. Thank you very much for your time. Have a good day.